Yep. Thank you very much. Thank you for inviting me. So, kidney replacement treatment or renal replacement treatment, renal replacement therapy, we talk about in the form of transplantation and dialysis, were two of the major advances in medicine in the 20th century. And here you can see Joseph Murray, who was the surgeon who performed the first kidney transplant in Boston in 1954. And he performed that in identical twins. And here are the identical twins a couple of years later being shown the new dialysis machine that they just bought in Boston and they were clearly very proud of. And we are now 59 years almost to the day since the first kidney transplant in the UK performed in Edinburgh by Sir Michael Woodruff here, who again performed this on twins. So major advance in medicine in the 20th century, and the number of patients with transplants is huge now, so several thousand even just in Scotland. So if I had IgA nephropathy, what I would want to know is, will I need a kidney transplant? If so, when will I need a kidney transplant? How will I get a kidney transplant if I'm going to need one? Who can be a living kidney donor? Because most of you will know that you can have living donors. How's a transplant operation done? And by that, I don't mean what's connected to what, but just what will happen to me on the day and what will it be like afterwards. What are the risks of a transplant? And will the IgA nephropathy come back in my transplant? So in the next 10 minutes or so, I'm just going to cover some of these, or all of these questions. And clearly, to some extent, we're only scratching the surface here, but I think during today, hopefully we'll be able to point you in the direction of other information. So the first question is, will I need a kidney transplant? In actual fact, for people with IgA nephropathy, that's probably the big question, because as John has already alluded to, the outcome for people with IgA nephropathy is highly variable. So some people, they'll have it, they'll get the diagnosis, they might need to take some blood pressure tablets, but that might be the only trouble they ever have for the rest of their life. For some people, they'll get deterioration in their kidney function, so much so that they may eventually need a kidney transplant. And in making these kinds of predictions very difficult, Yogi Berra was a famous baseball coach, and I think we would all agree that it is tough to make predictions, especially about the future. But that's what we need to try to do, and I'll explain why. So when we are seeing you in the clinic, what we're trying to do, and John said that we used to do it with graph paper, but fortunately for many years now we've had computers that can do this. We're trying to draw a line through the results of your kidney function. So we talk about this thing called eGFR, which above 60 is normal, below 60 is abnormal. Once you're getting down to zero would be, you can't survive with zero. But once you're down to round about 10-ish, and it varies from person to person, but round about 10-ish, the waste products in the body are building up enough to give you symptoms that really you're feeling unwell enough to make the downsides of kidney replacement therapy in the form of either dialysis or a transplant worthwhile. So we're trying to think, when will you reach 10? And if you do reach 10, the options are transplantation, dialysis, or let nature take its course. And most people will choose, if they've got a choice, transplantation. And the reason for that is because people who, and I'm sure there are people in the audience who have been on dialysis and had a transplant, will tell you that on average, you tend to feel better with a transplant. And in fact, some people will tell you feel much, much better with a transplant than you do on dialysis. And that's not a great surprise, because you're replacing kidney with real kidney, as opposed to a machine. The other thing is there are fewer restrictions with a transplant because there aren't so many dietary restrictions. You don't have to be in a certain place at a certain time 3 times a week. Much more freedom to go on holidays, work, etc., etc. So most people will choose a kidney transplant over dialysis. But you need to be fit enough to get through an operation. And so maybe about 50% of people who end up with kidney failure with an EGFR of about 10, maybe about 50% are not fit enough to go through the operation at that time. But if you can, you probably would want to have a kidney transplant. So how will you get a kidney transplant? Well, there are two ways of getting a kidney transplant. One is from a living donor, and one is from a deceased donor. And there are differences in the two. In general, you are better with a living donor than with a deceased donor. That's not to say a deceased donor kidney is a bad thing, but in general, better with a living donor. And the reason for that is because we can be more confident about the health of the person who is donating the living donor, because we've had plenty of time to do lots of tests to work that up. Whereas with a deceased donor, we don't maybe have so much information. And you can imagine the deceased donor has been through, their kidney has been through a lot at the time that the person who's deceased is dying, and then the kidney is transported in ice to wherever the transplant is going to take place, and that causes some damage to the kidney as well. So if you can, you're better to get a living kidney donor. Of course, not everybody has a living kidney donor available, but if you can, that's the better option. So who can donate a kidney? Well, essentially, any adult is eligible to be considered as a kidney donor. They don't have to be a relative. They don't have to be have particular characteristics. But if somebody comes forward as a potential donor, they will go through a very rigorous process. And that process will involve ensuring that they're well informed, ensuring that they're in good health to be able to come through an operation, ensuring that they have a good kidney function in both of their kidneys, and they don't have any evidence of a kidney disease at present. So anyone can be considered, and there are quite a lot of myths out there about, well, what if somebody's blood group A and somebody's blood group B, that's all off. Well, that's not necessarily the case, and now with the National Kidney Sharing Scheme in the UK, which is really quite an amazing resource, we can swap kidneys around even if the person can't donate directly. And if you are considering transplantation, and if you are wondering who could be a living donor, then don't believe many of the myths you might hear in various places. Come and speak to us, or come and speak to the transplant team about it. Is it possible? And we try not to rule anybody out early on. We, in Glasgow, I'm sure the same in Leicester, we've had just about every relationship you can think of donating. So, for example, sister to brother, friend to friend, spouse to spouse, niece to uncle, etc. Probably about the only one that I don't think we've had yet is daughter-in-law to mother-in-law for some reason. But we have. If you look around the world, there are actually more female living donors than male living donors, which is quite interesting, and you might consider why that should be. There are quite a number of reasons why that might be. In Scotland, that's not the case. In Scotland, there are as many male living donors as female living donors. And when I saw that for the first time, I was quite pleased, and I thought, well, that's presumably explained by the fact that Scottish men are a bit more enlightened, a bit more generous. And then somebody pointed out to me that perhaps it's that Scottish women are a bit more scary. So it's all about planning, and that's the key. It's about having the confidence to say to your nephrologist, hopefully your nephrologist will be saying it with you, is, will I need a kidney transplant? What's happening with my kidney function? What's going to happen if it keeps deteriorating? So that you can get the conversation going, because the key thing is trying to plan early. In my opinion, probably when I think somebody might be 2 years away from it, that's when I think we really need to have the ball rolling here and discuss this. What are we going to do if things keep deteriorating? And that can be a difficult conversation because the person is usually feeling absolutely fine, and it can be a bit of a shock. But I think we need to do that. And that's because if everything goes swimmingly, to get a live donor ready for transplant, it's about 3 or 4 months. but there are often hitches, there are often extra investigations needing done, etc., etc. And it's much better to have a living donor in place who's all worked up, is going to donate, and not need them yet, and just wait till the time is right, than try to rush it and risk maybe a period on dialysis, which can be quite disruptive. So it's all about planning. Hopefully do a bit better than these builders. How's the transplant operation done? So the main things that sometimes surprise people is if you're going to get a kidney transplant, it goes in down here. And the surgeons don't take out your own kidneys. They just leave them where they are, and the transplant goes down here. If it's a living donor transplant, then you will have been given a date in advance, and you'll know when you're coming in to get it done. The deceased donor transplant, when you're on the waiting list for that, and you can be on the waiting list on average of 2 years in the UK now, you can get the call anytime. It could be a day after you go on the transplant waiting list. Unfortunately, it can be longer than 2 years as well. So you might get the call, and you come into hospital, and it's a bit of a rush job to get all the tests done that are needed to get an operation and the kidneys and they get the kidney done. And you go down to the theatre and come back with various tubes in place, and then afterwards, over the next few days, we're watching you very carefully. This is us in Glasgow yesterday in the transplant ward around, keeping a close eye on you. And you're in for an average of about 7 days. So some people will be a bit longer if there are complications, and then you'll be followed up very closely in the transplant follow-up clinic after that. And what are the risks of kidney transplant? Well, if you are going to get a kidney transplant, you will get very detailed information about risks, both at the time of assessment and then on the day of the transplant. But the key thing is that we know that the human is designed to reject foreign tissue. So if you get a foreign organ put into you and no medication, your body will just reject that kidney, and the kidney won't work. So we have to give you medicine to take every single day to prevent rejection of the kidney. They're good medicines, so we don't see a lot of rejection. We still do see some episodes of rejection which can be treated. So if you hear the term, the doctor saying, I think you might have some rejection in your kidney, that does not mean to say you're about to lose your kidney. It just means that the immune system's winning the fight at the moment, and we just need to dampen it down. But these medicines are very good, but the problem is they also dampen down your ability to fight infections. So you're at increased risk of infections. What sorts of infections? Just the infections that we're all at risk of because of the environment that we live in, coughs and colds, etc., but also some more unusual infections that we have to be very careful about. So that's the big downside of transplantation. But when we weigh up the benefits and the risks, usually the benefits outweigh the risks substantially. And finally, will IgA nephropathy come back in my transplant? John has already alluded to this. If we look hard enough for it, we'll find it in about 50% of people with IgA nephropathy who then get a transplant. But it appears that it's not a huge problem. So we definitely do see people where over the years the kidney function is going down, and we investigate with a biopsy of the transplant kidney, and we think, well, actually, it's the IgA nephropathy that's causing the problem here, and it will tend to keep deteriorating. But most people in whom we can detect IgA nephropathy in the transplant kidney is not causing a huge problem. But if you don't know about it, you might be alarmed when you hear that the IgA nephropathy has come back. So transplantation is a fantastic treatment when it works. Lots and lots of people around the world have been helped by transplantation, can get back to very high quality of life. It's not perfect, and hopefully we're still managing to improve. Well, we know that the outcomes are improving year on year for transplantation. It's not perfect, but it is a great treatment when you consider what the alternatives are. And I think sometimes we're all afraid of asking particular questions because we maybe don't want to hear the answer, but I think it's really important for you to be empowered to ask the question in the clinic, am I going to need a transplant, and when should we start planning for it? Thank you very much.